if you're a lab owner, if you're a healthcare administrator like myself, what do you want? You want your providers to be able to practice medicine the way they need to practice. And proper medical necessity documentation allows them to keep doing that because they can properly document, and that way they can prescribe the regimen that needs to be prescribed. They can proceed with an interventional care. They can do a surgery. But if the documentation doesn't exist, right, they can't deliver that care. For a reference lab, the best thing that you can say is that we care so much. Not only are we going to get you these results, that we're accredited as a lab, but we're protecting every single one of your providers because we generate this documentation to keep you safe, because we generate all the medical necessity for every single analyte that you've tested.
And that's where Solarian steps in. Solarian solves the problem of documentation by automating compliant medical necessity documentation so the providers can continue to provide care. We take the work off of their load and we help them. It's a clinical documentation support tool. And so we help the labs by helping the labs get the documentation they need in order to support reimbursement and to stay compliant. And we help the providers by helping support them in terms of documenting the things that they don't have time to but need to.
This is part 2 of a 6-part series about labs, money, and business solutions to problems vexing the industry. I'm Cecily Korst, and I'm here with Mike Liu and Dr. Michael Sprintz. What is medical necessity documentation and why does it matter?
Medical necessity documentation really it's the backbone of the delivery of clinical care, and it's the lifeblood of reimbursement. Medical necessity is the justifiable reason for why I'm doing a test or providing a service for a patient with a condition that warrants that service. So the purpose of identifying medical necessity from a clinical perspective is the simple question of, why am I doing what I'm doing for this patient? And does that make clinical sense? So running tests on patients that don't need it, or performing a service for a patient, let's say you do a surgery on someone who doesn't have it on their arm and they don't have a problem for their arm, well, that's not medical necessity. But medical necessity is there as a reason to document and justify why we are doing what we are doing as healthcare providers. So it's absolutely necessary from a clinical perspective, because if you can't justify why you're doing something, why are you doing it? And that's a problem. So that becomes an issue of competency, right? So a healthcare provider, they need to show that that the decisions that they're making are consistent with standards of care for whatever that specialty or service is. And then it's also another means of, on a secondary side, of preventing fraud or abuse of medical services.
So where did this originate?
So medical necessity originated as medicine originated. We're talking hundreds of years ago. The way we know everything is by writing it down and passing on that knowledge. So over the course of centuries, as healthcare providers had interesting cases, or they would document what they would do and why they would do it, that created the foundation, not just of medical necessity, but of documenting what's normal, what's abnormal, and what problems and what solutions did we try to fix these problems. If no one had written down that they used leeches as the solution, enough people did this and enough people documented that it wasn't working. And it actually was causing harm. And so documentation of care and documentation of the problems it's an essential part of good medicine, and to evolve the knowledge base of society in general and of medicine. So in the modern times, they became the chart notes. We used to write on paper charts, and we would document what we saw, subjectively, what we saw objectively. We'd come together with an assessment of what was going on, and we would have a plan for what to do. And the purpose ultimately was that so someone else could pick up that chart and see what we were thinking and what our thought processes were. And that's really where medical necessity evolved out of that, or is part of that, of this is what is going on, my assessment, diagnosis. So I evaluated the patient, I ran the tests, I did the exam, I did all of the information gathering, and this is what I believe is happening. And my plan is, this is what I want to do and why I want to do it. And that's really where that encompasses more than just medical necessity, but that's the essence of it, is what I'm doing reasonable and necessary based on the evidence that we have at that time, whatever evidence based on the standard of care is at that time. And then over time, especially in the 80s and 90s, as we started to have insurance come in healthcare, that's when medical necessity and documentation became an essential part of the revenue cycle management, of basically getting paid for the work that you do.
Enter in the payer system. Help me out, Mike.
So being able to pay for first-party services in a transaction, I buy an orange, I pay for an orange. In the old days, you provide a service to me as a physician, I pay you for those services. So in the 80s and 90s, we created a third-party payer system. President Johnson created this with Medicare in the late 60s, right? And we understand this. Medicare was the first true third-party payer, and we've estimated that since its inception, there have been tens of trillions of dollars of fraud, waste, and abuse that has gone through the system. What happened in the 80s and 90s is you saw providers, hospitals, clinics, laboratories, anybody that was rendering designated health services, billing for things that they did not do. Lots and lots of fraudulent billing go through the healthcare system.
That's
Medical necessity is important, like he talked about, from a clinical perspective, but also from a revenue cycle billing and coding perspective. So for instance, if you've got a broken arm, we will pay for the repair and the splinting of that broken arm if it meets one of these 20 criteria. Is there a broken ulnar? Is there a displaced elbow? Something that has to do with the arm, right? So medical necessity has to be documented in the chart and has to be coded a particular way.
I think it's important too that we acknowledge there are good actors and there are bad actors. The vast majority of providers do the right thing, try to do the right thing, they're compliant, they're not fraudulent, but there are some that may be ethically challenged, if you will, when it comes to fraud or abuse or overuse. So sometimes they're not billing for something that they didn't do. Sometimes they're doing a procedure over and over and over again that may not be necessary. And so that's really where the key is, finding a balance between supporting appropriate and medically necessary services and minimizing the fraud, waste, and abuse. I think that's really significant, is that the finding that balance has been hard, where I think sometimes the payers and the government have used the prevention of fraud, waste, and abuse to deny a large swath of services that really are appropriate under the umbrella of fraud, waste, and abuse, where if it's not documented, it didn't happen. And that's really important. Well, did you read the x-ray, doctor? Well, yeah, I read the x-ray and it was fine. Well, there's nothing here that says it's fine. So now we had to repeat the x-ray, because we don't know what the answer is. We don't know what the thing are. Or did you order it? Yeah, I ordered it. Well, we don't have any evidence that you ordered it. Well, I called down and told them to order it. Maybe they did, maybe they didn't. So if it's not documented, it didn't happen. And that's really where the documentation is necessary now, especially as it comes to reimbursement, because the payers want to know, hey, look, we want to know you actually did this service. So document this, sign your name to it, that you as a provider or as a DME company or as a lab or as an imaging center, I need proof that you stand by this, that you attest that you provided these services for these reasons.
So can one of you or both of you talk about it from a lab perspective specifically?
So there are two angles here. Is it a lab that is yours, that you own, that's part of your practice, what we call a POL lab? Or is it a reference lab? So very importantly, if it's a POL lab, the owners of the lab can control their own destiny because they're being paid for those services. They see the patient, they're doing the testing in-house, and their documentation matters. So there's a liability on that provider, on that practice, and there's remuneration that happens from a third-party insurance company or payer directly to them. That's first-hand liability. The second scenario is in the case where you actually send your samples to somebody else. In that case, they are responsible for making sure they have all the documentation to be paid. So remember, the medical necessity still exists, whether it's first party or second party. And that has to be documented, that has to be in the chart, and upon audit, that needs to exist.
And that's where the problem happens. And the problem happens, like we talked about in the last episode, the challenge for reference labs, not only to just get the documentation, but to get documentation that is detailed enough to support medical necessity. And that's really where this whole problem happens, is that the payer is the third party. And again, the payer is requiring the lab to chase down their customers and ask their customers to do more work so that the lab can get paid. It pits the lab chasing down customers, asking them to do more than they would, because the medical necessity requirements for laboratory diagnostic services, especially with drug testing, it's excessive and egregious. It's not just you need to justify, why am I testing this patient, right? It's not one medically necessary reason. Why am I testing this patient? Well, this patient has a substance use disorder, or this patient is a chronic pain patient on opioids, and I need to make sure that they're taking their medication. That's not enough. The requirements that the payers now are saying is that you need to have a medically necessary reason that is patient-specific for every analyte you're testing. And when I say analyte, I mean if you have a 30-panel drug test, you need to come up with a reason for each and every drug on that test.
And when they come back and say, no, we're not going to pay for this, they call it insufficient.
Yes, you did not demonstrate medical necessity. This is coming from my perspective as a clinician practicing with my own physician-owned lab and having worked in this space now for over a decade, of seeing how the revenue cycle goes and how the denials are. And as most people in the healthcare industry can attest to, the denial reasons seem absolutely arbitrary. Like, sometimes they'll approve something and sometimes they'll ask for medical records. Sometimes it's okay, sometimes there's not a logic that is easily discernible from our standpoint as providers. Now, when you think about the economics of it, though, then it starts to make sense. Overwhelm creates poor documentation because it can't get done. So as a payer collects the premium dollar, and the longer that they can delay payment, even if it's approved and gone, the longer they can delay payment, the insurance companies, they're making billions of dollars per quarter. And what do they do with it? They invest that. So for every day that you have $1 billion or $6 billion invested, you make interest on that. So if you can delay payments 30, 45, 90 days, that's a lot of interest. That interest is probably more than what that claim was worth.
Wow, they kept collecting premiums. Let's go back to the clinical problem here.
Okay.
So I have run practices from 1 doctor to 400 employees. And one of the things that we see is, how do you get by so that you are as efficient as possible? You're typically using a template of some kind. So most providers will have a template for new patients, pain patients, established patients, kidney patients, diabetic patients. Sometimes there's a hip and a back template. So they try to operate as efficiently as possible. No template is ever going to be perfect, right? No provider will be perfect. So we know that there's human error automatically built into the system, right? And when you have 10.7 minutes to see a patient, most providers, approximately 85% of charting happens after the encounter actually occurs. So you're taking whatever notes you can during the encounter, and then you're finishing up your notes later that afternoon, during your free block, in the evening. In the practice that we were a part of, and in his practice, in practices that I've run for 25 years, it was always impossible to get providers to document enough for us to get paid on claims, specifically laboratory claims. That's phase 1. If you're a reference lab receiving samples, you have very little control of the documentation that's actually coming into you. So if the standard is so impossible, and like you said, you have to document for every analyte being tested, literally it is an impossible feat to do this without an automated solution.
And what's interesting about laboratory, so in a lot of medical necessity services, when we talk about evidence-based care, right? So this is the appropriate way to evaluate and work through a treatment plan for a certain disease, right? For like low back pain or for something like that. And so templated notes, they're usually okay for other services. They're totally not okay for lab. for other things like for providing services, in a lot of areas of medicine, it is expected that you follow a certain standard, a certain protocol. And for whatever reason, the payers have said, no, not here. In laboratory, especially in drug testing, it has to be unique for each and every patient. The reality is, when you have a patient with, for instance, a substance use disorder, there is, as physicians and clinicians, we go through treatment algorithms. Every patient is unique and there are different situations. But the level of specificity in documentation that is being required for laboratory, especially toxicology, but it really extends to a lot beyond that, is it's over and above what you see in other areas in healthcare. And in other areas in healthcare, like in the pain management space, we have a framework templates for certain visits and certain problems that you edit and you change because it is a unique patient who may have certain symptoms but not others, or have different issues going on, and you edit that. But there is a general form to it in terms of the logic of how you go and document. That's not the case. And that's really where it's impossible to get this done in the laboratory space, especially in the toxicology space. For a clinical lab, like a reference lab, or even a physician-owned lab, couldn't get my own partners to document well enough. And to be fair, because the amount of time it would take, in addition to everything else that we're doing as providers, to document this as well, it's just overwhelming and impossible. And if you have a life and a family, and that's really important to have a life and a family, or a life filled other than just administrative duty and patient care, I need fuller lives, and I think most providers are feeling that as well.
So he brings up a really great point. Once again, if the lab is a POL lab, physician-owned lab, you're protecting your own clinical and financial liability. If you're a reference lab, the biggest thing that a reference lab can do is to protect its referring sources. So not only are you protecting your claims dollar and getting paid for the services you rendered as a reference lab, but now you're also protecting your referral source. You're protecting every single doctor, PA, nurse practitioner, clinic, any provider that is sending you samples. You're properly documenting in a way that they cannot.
And that brings up a good point. Unfortunately, most providers, healthcare providers that are doing patient care, they don't really grasp and understand the risk that they face for non-compliance when it comes to documentation. And so we know that fraud is billing for a service that you did not perform. Okay, separate issue. What I'm talking about are overuse or misuse and abuse of healthcare services. So if a provider is ordering a bunch of lab tests, which may be appropriate, right? It may absolutely be appropriate, but again, if it's not documented, it didn't happen. If it's not documented and the medical necessity is not documented, what the providers don't realize is that they are at risk for investigations for abuse of healthcare services, for misuse and abuse. And that's something that they're like, well, I'm just sending it off to the lab. It's the lab's problem. It's not just the lab's problem. It's not just about reimbursement. And everyone talks about reimbursement, obviously, because it's dollars. Margins are going down, and in healthcare, it's really hard to build a very successful, efficient practice, and it's getting harder. And so every dollar counts. And when you're looking at a laboratory, especially in the tox space, with a 25, 30, 40% denial rate, that is a massive amount of money that cannot be recaptured without the documentation that Solarian provides.
Solarian helps labs just do the documentation.
Solarian automates medical necessity documentation to help labs and providers stay compliant, get paid, and stay safe from an audit perspective.
We've talked before about how there are payer limits for every patient. And so on a typical plan, a patient will have benefits to get tested once a month. We had a situation where we had a number of patients that had to go through high-risk opioid clinic. So even though the plan only paid once a month, we actually, because of proper documentation of medical necessity, got drug testing approved every single week for patients, because that documentation existed, and we were able to prove to the medical board, to the payer, that this was necessary.
It was clinically necessary.
For the delivery of care.
These were patients that were at much greater risk,
Yeah.
and it was clinically appropriate care. But we had to document that because it went beyond the scope of what is considered the payer-imposed limits. And so the payer makes these limits for however they determine those things. What we find is that often they'll reference peer-reviewed articles or professional society recommendations.
Standards of care.
But what I have found is that they often pick and choose which documents to reference. And especially like I remember a while back, one of the payers had referenced an older ASAM document to talk about things. And of course, times have changed, and the 2017 guidelines that the expert panel put out were much more appropriate and detailed and instructive, yet they only reference that for one small test matrix. And it had nothing to, they completely ignored all the guidance, and they used older stuff that fit the way that they had wanted to write their policies.
This impacts quality of life or even life and death.
It absolutely does. So that's a big problem here when you start to talk about drug testing. Why do we do drug testing? Well, we want to make sure that the patient is compliant with their medications. They're taking the medications they're supposed to be taking, and they're not taking medications that could risk them from either a drug-drug interaction, which can cause what we call a synergistic effect. So you could run into an overdose problem. You can run into organ failure problems. You can have anaphylaxis. You can have an allergic reaction. And sometimes patients don't either tell us necessarily what they're taking, or they may not know some of the things that they may be taking. And when you're talking about the chronic pain space and the substance use disorder space, so you've got two very high-risk patient populations. And one of the things that's happened over the last 10 years with the opioid crisis is that the availability of prescription opioids from physicians plummeted after 2017. Everyone got scared. People were worried about going to jail. People were worried about, overdosing their patients. And so the pendulum swung so far in the other direction that hundreds and thousands of patients who had been on long-term chronic opioids were suddenly left high and dry. And so they had physical dependence. And what do? You try to go to another doctor. If they can't find another doctor, it drove people to the black market. And I always remember this. There was a news show that came on. They're like, well, we've had a really fantastic drop in the number of opioid prescriptions that are going out to patients these days, but we've had a surprising increase in overdoses of illicit opioids. And I was like, oh, come on, people. You didn't see this one coming?
Yeah.
Yeah, for anyone who's not been through opioid withdrawal, it is absolutely horrific. I'm not even talking just people with opioid addiction or opioid use disorders. I'm talking about people who are physically dependent on opioids, who've taken them for a long period of time, that they're suddenly in withdrawal, and it is horrible. And as a clinician, if I'm prescribing a medication that could have a potential interaction with these patients who are very high-risk patients because of the nature of their conditions, whether it is addiction or whether it's chronic pain, we want to make sure that they're safe. And so the reason why we need drug testing is if someone had diabetes and I'm prescribing insulin for them, and I never check their hemoglobin A1C, or I never check their sugars, and I never check, but they're like, yeah, doc, I feel fine, I may need a little bit more, and they up it. I'm committing malpractice, right? If that patient dies and I never checked, if I'm prescribing blood pressure medicine and never checked their blood pressure, no one would argue that is malpractice to keep increasing that. So as a pain provider or a substance or addiction medicine provider, I'm caring for patients who are at high risk for overdose or death with some of the medications that I'm prescribing or some of the medications that they may be taking on the street. Drug testing is a necessary part of good clinical medicine. And if no one is going to get reimbursed for that, if no one's going to get paid for the services, people will stop doing the services and people will die.
If you're a lab owner, if you're a healthcare administrator like myself, what do you want? You want your providers to be able to practice medicine the way they need to practice. And proper medical necessity documentation allows them to keep doing that because they can properly document, and that way they can prescribe the regimen that needs to be prescribed. They can proceed with an interventional care. They can do a surgery. But if the documentation doesn't exist, right, they can't deliver that care. And a paper trail is often needed. So in the reimbursement world, we are required by law and clinically, just for ethical reasons, we are required always to exercise diligence and provide the least interventional, the most conservative therapies first. So if you're a doctor and you're thinking, oh, well, I need to try this for at least 6 months, you cannot continue that therapy for 6 months unless you've got the documentation to do so. And then a doctor's always thinking what's next, right? So as an administrator, I want my providers to be able to prescribe the medication regimen and then go through the interventions, go through possible surgeries, do anything they need to deliver clinical care. And for me to get paid for it, I need to make sure that that documentation is there. For a reference lab, the best thing that you can say is that we care so much. Not only are we going to get you these results, that we're accredited as a lab, but we're protecting every single one of your providers because we generate this documentation to keep you safe, because we generate all the medical necessity for every single analyte that you've tested.
And that's where Solarian steps in. Solarian solves the problem of documentation by automating compliant medical necessity documentation so the providers can continue to provide care. We take the work off of their load and we help them. It's a clinical documentation support tool. And so we help the labs by helping the labs get the documentation they need in order to support reimbursement and to stay compliant. And we help the providers by helping support them in terms of documenting the things that they don't have time to but need to.